just joined us. So on to the minutes. We'll go through them for accuracy. We take items through to 3 first. 4.
I just wanted to pick up on page 9, on 4B, the second to last paragraph on page 9. So it said, and Mr. Germain informed he could share the complaints reports. I think we comment on the individual complaints, but I was going to check if the region or there was any other reports that that aggregated, but there aren't. So I think it's more that I was going to check if there was a complaints report to share, and there isn't.
Okay, thanks for that, Nick.
Okay.
So, sorry, Sam, is there any chance that we can get any detail? We sort of get some that come through directly to the CCG, and we then send on to or we advise the patient to add a complaint to the GP practice and then escalate to NHS England. But we only get a disproportionate sort of sample, I suppose, of our complaints. There's no way we can get a fuller picture at all, just by theme.
Yeah, there's no standard report, but I guess we can ask the complaints team are in contact with us to feedback on complaints or to escalate complaints and things. So I can ask them if there's some way we can get some sort of bespoke report for Bassetlaw. Yeah. It's
just useful if we get something that's, let's say it's all around access in one practice, and we know that we don't at the moment, we don't know that. For all we know, quite a few patients might be complaining about, I won't pick a practice, but a certain practice's access. And we maybe get a sample of that, but we don't understand the full picture. And I think it would be useful, then we can support the practice sometimes to improve in that area, or we can certainly raise it at the practice quarterly meetings.
Yeah.
Thanks.
Answer that way. Okay.
Thanks, Nick. Thanks, Andrew. 5 around service development, 6 on finance, 7, 8, 9, 10 through to 14. So, Hesh?
Thank you. Just 3 things for me, really. The first one is probably for Nick in relation to the complaints question. I wonder whether it's possible to, even at a practice level, when the practice is asked to respond to a complaint that's gone to NHS England, whether we can get some feedback, because we've had a few over the years that patients have made directly to NHS England, and NHS England ask us to respond back to NHS England, then we coordinate. I've not received any feedback from that process, whether it's resolved or not, if there's any learning, etc., etc. Yeah. So,
the complaints team should send a sort of outcome letter to the patient. I think they sort of do the investigation or gather the different responses and do an outcome letter. So where the outcome letter could be
copied to the
routine.
GP. Yeah, that would be helpful, just so that we can close the audit loop. That'd be helpful. My other 2 are in relation to points of accuracy. The first one is under item 5B, Health Watch Long COVID Service Update. It is page 13, 3rd paragraph from the bottom. I think it's a second to last sentence that says basically support available through expert health, respiratory nurses for patients with respiratory problems. And it says or COPD. I don't think, yes, there's support for COPD, but this is in context of long COVID patients. So I wonder whether you could say patients with respiratory problems and talking therapy support via Insight for long COVID patients, because those are the 2 things that the current long COVID pathway offers. So that's that one. And my final one is under item 14A. Again, this is the bit that I'm sort of referenced. So it says Dr. Arison asked if lateral flow test allocations are being recorded to review the proxy measure for COVID levels. can that be changed to are being recorded and used as a proxy measure of compliance with published IPC guidance by NHS England? Because that was the question that I asked. So whether there's any data gathering centrally to use as a proxy measure for measuring compliance. So can that be changed to are being recorded and used as a proxy measure of compliance with published IPC guidance by NHSE?
Okay, thanks, Hesh. Is that okay, Charlotte?
Yes, thank you.
Okay.
Thank you very much.
Thanks, Hesham. Okay, on to the action log. The first couple are around GP appointment data. Andrew, Nick, do you want to come in on that?
Sorry, they're sorted, Sam.
Okay.
All our practices of the line have mapped it all over. They did it all by the deadline. There's no other issues, is there, Nick? I had a look and it all looks pretty good to me.
No, yeah, I think the appointment data is discussed at primary care leads, and I think most recently there's the issue with the availability of July data. But
yeah, the GPAD data, I put the basic data on yesterday and I sent out a link, but I don't think it's there for July. We were expecting it had been uploaded for July, but most of it's there now, isn't it? So yeah, it'll improve, I think.
Okay, so we can put those to as completed. They're all completed.
And I had another action under the estates, the third one up. It was about checking if there's support for completion of estate strategy. So I gave a bit of a partial update last time, but I guess just to close it off, the primary care development funding sits under the SDF, so System Development Funding, which is amalgamated some of the GP forward view. And for the PCN development funding, the agreement for this year is to allocate it to the CCGs, for the CCGs to hold it. And then there's some description about how it could be used, but primarily on things identified in the PCN development plans for each PCN. So if estates strategies was a development need, that could be used. But it doesn't sit with South Yorkshire Bassetlaw to look at if there's a theme for that. It's been devolved to the CCGs to hold and use that as needed.
Okay, Hesham.
Thank you. Just a couple of points of clarification for two items that have been marked as complete. The first one is the first COVID update that it's addressed to FAE to liaise with the council to see if they're supporting any work on vaccine hesitancy, especially around care home staff. It's been marked as complete. Have we received any summary of what work they're doing and what the outcomes have been? Because I'm not quite sure. I'm not quite sure when we complete it. Are we saying FAE's asked and the council said yes, and that's it, or are we saying the action is complete? Are we satisfied that we've received something that is happening and it's been monitored? I wasn't quite sure what from the word complete what it meant. That was the first one. Does anyone want to pick that up?
Andrew?
I'm not entirely sure, Hession. I know we've done a lot of work with care homes around hesitancy. Probably Rachel Bussey would be the person to pick that up, because she's been the person liaising from our perspective. Victoria?
Yeah, it has been raised, Hesh. I know that it has been raised and discussed. We've actually also mentioned it as part of the Bassetlaw provider collaborative meetings. And I do know that Notts County Council are working hard with care home providers to try and encourage vaccination uptake amongst staff. But I couldn't give you specific actions that have been undertaken to do that. But I do know that they are having those conversations and encouraging them.
Okay. Thank you.
Idris, do you want to come in?
Yeah, just to add, I think in terms of this committee, we've raised it. It's not our responsibility to deliver. We're aware that they're doing things. And of course, there's the consideration about compulsory vaccinations being made somewhere else as well. So I think, personally, I think it's fair that the action is complete as far as this committee is concerned. Obviously, the work is ongoing.
Thank you.
Just to add to that, Sue, it has been raised, hasn't it, at QAPS as well? So it's on that radar, and we've got a QAPS meeting next week.
Yeah. And my final point is in relation to COVID update, which the one that's got lots of red text in it. It's the last comment in the red text. Sorry, I've got someone parked outside my window. The final paragraph says, as DBHD are providing antenatal care, it is thought that any fertility concerns would need to be picked up by primary care which makes no sense because they're the ones who are delivering the vaccination program. And if patients have concerns about the vaccination causing fertility issues, why signpost them back to primary care? I don't have any additional information other than what's been published, and that reassurance coming from the specialist is probably far greater than that coming from a GP. So I'm not quite sure why that's been bounced back to primary care.
I agree, Hesh. I think that can't be right, because I know that there's been a lot of work with midwifery and generally, I don't think that makes a lot of sense. I'll pick it up with Faye and see if she meant to put that, because I think it's with maternity services.
Thank you.
Okay. Thank you, Hesh. Any other matters arising from the minutes or the action log? Okay, no, thank you. Andrew, we need to formally note the approved virtually incentive scheme. First item 4A.
Yeah, it says this has already gone out virtually. Since then, you'll note that further down the agenda, I've put in the investment and impact fund and what's expected that generally of the PCNs. And as we expected, there's a bit of an overlap, I think, particularly around the inequalities work. But actually, it's a big thing for the PCNs. That's really what they're there for, I think. Anyway, it's a major part of their function. So I'm not too concerned that there's a bit of an overlap, and a lot of the work that they've got to do nationally is preparatory work, whereas we're going a bit further and pushing them to do, or funding them, I should say, to do more reviews of vulnerable patients, etc. So I'm quite happy with the way that they've dovetailed in actually the two schemes. I don't know if anybody's got a view contrary to that, but anyway, we've already approved it virtually. It's already gone out to the practices, and now we're working on plans to deliver it.
Okay, Victoria?
Yeah, Sandra, I just think it's worth noting that we knew that it was likely that those kind of initiatives would come through there. It isn't by accident that we've dovetailed into it, it was by design. So yeah. I think it's important to note that what we're asking for is an accelerated delivery in year as opposed to waiting, but it does help, I think, our PCNs to kind of ratchet up the work that they are going to be expected through other schemes.
Yeah, it's what we've tried to do really for the last 5 or 6 years. We've tried to anticipate what's coming down nationally and do quite a bit of the groundwork, preparatory work, rather than having two things completely separate. So yeah, I agree. Just we didn't want it to be overlapped too far, did we? And then we might be double paying, but I don't think it does.
I think the next thing for me will be clarity around understanding delivery against the elements in the incentive scheme and bringing reports back to this group so that we do understand impact on what we're funding.
Okay. Andrew, could you fetch a report back to the next meeting then with a bit of an update?
Yeah, I think we'll only have plans and some delivery by then. It'd probably be more that we'll get at. What we generally do is we review it around about Christmas time to see what the delivery is and to also make sure that we're not overpaying. So I'll bring back something next and an update each time, but I wouldn't expect an enormous amount at the next committee. It'll be the one after that.
Yeah, we've got 5th of November is the next one, so yeah, see where we are. Okay, thank you. So can committee just need to formally approve that it has been virtually approved. Thank you. And Victoria and Idris 4B ICS transition update.
Yes, thanks, Sam. I'll rattle through sort of at a higher level the different aspects of this, and Victoria can come in, probably talk in particular about place and maybe our aspirations around primary care, since this is the primary care sort of committee. So we're working on a number of key documents setting out the sort of the principles and the roadmap of the transition into the net-to-entry system. So that includes the transition principles, in particular about staff below board level and actually now sort of at board level. So how that's going to be handled. We're looking for a smooth transition for all those below board level. So retaining current roles. That's now with senior people across the system to formally consider and hopefully approve. We've also got a draft MOU or collaborative agreement between the two ICSs, South Yorkshire and Nottinghamshire, setting out how they would work collaboratively together on a range of issues.
Make your computer easier to use.
Thanks, Andrew. And also about what the regional relationships will be, because obviously this isn't just a transition in terms of ICSs, it will affect which NHS England region we're in as well, which has a number of implications. The programme itself is sort of been established now. We have 12 work streams. We've got identified leads within the CCG for every one of those, and they're making contact with counterparts in Nottinghamshire to take that forward. And we're also we've received, distributed and starting to complete the due diligence sort of pro forma as sent out by NHS England. There's also a range of OD that is being carried out. So there's joint OD programme now with across the Nottinghamshire systems, including ourselves. There's been a number of senior stakeholder interviews across the system to really set a baseline about the views of stakeholders to help inform the OD programme, and there's a workshop that's going to be held. I think from our perspective, Victoria and I will be at that to start working through the detail. We've also got support within our own organisation in terms of OD and staff, and we'll be working on that. And the final element of OD is working with partners across the place on a collaborative basis, and Victoria will come back on that. We've also submitted from some external non-recurring support to NHS England. Obviously, this is quite a significant task for us, particularly as a fairly small CCG. So we have put in proposals for additional support to both backfill and to enhance sort of the resource that we have to work on this. We've already started putting some of that in place. So Victoria will mention, I'm sure, sort of some of that that's already in place, and but there's more to come, and I'm optimistic that will be approved very shortly. And then there's the place-based arrangements themselves, developing both what the functions that currently reside in the CCG look like at a place in future, and like I say, we're looking for a very smooth transition on that. What the management team looks like to support all of that and those staff, and then the place-based collaborative, in particular working with providers, and Victoria's doing quite a lot of work around developing that. And that also has implications then to be agreed about the level of delegation from the Nottinghamshire ICS to the Bassetlaw place. But Bassetlaw will be a place in its own right. That's one of the transition principles that we've put forward, and there's no opposition or disagreement about that. So we are expecting a pretty high level of control, but we are looking at that quite carefully in terms of ensuring what we've got is a high level of control as to the key areas, as opposed to a low level of control of a lot of things, if you see what I mean. It could look like we have got a lot, but actually if it's not really under our control, we haven't got influence over it. That's what we're actually after. And that includes continuing working with primary care, because I think that's a place-based work primarily. Victoria will no doubt want to add, supplement that.
Thank you, Chris. I've got a slide that might diagrammatically illustrate what Idris has just demonstrated. If you'd like me to share that, Sam, just to emphasise. Can you see that okay? It's a bit detailed, so I'm very happy to send this round afterwards. But just to illustrate the kind of overall arrangement that we've got in place and reflecting some of the points that Idris has just said. So obviously we've got the internal task and finish group established within the CCG. We've got admin resource by Charlotte that's going to come into there, currently supported by Lindsay at the moment. We have gone out for advert to get some additional support in that will release Charlotte to enable her to have capacity to help us a little bit more. We've also now commissioned additional programme management resource. So we've got a gentleman called Mark Wall, who has now joined us this week. and he'll be working with us to ensure that we've got appropriate programme oversight of the different tranches of work that are underway. This shows you how the task and finish group will feed into governing body arrangements, audit committee, PCC, and keep people updated and reporting as required, as well as reporting into the Nottingham and Nottinghamshire ICS governance arrangements, and specifically at the moment their transition and risk committee, which has oversight of risk of transition. What this diagram illustrates is the key themes of work that we're undertaking. So there is, as Idris has mentioned, the due diligence for the close down of the CCG, with key themes within there that are owned by individual executive leads within the CCG. We've got the transition moving away from full membership of South Yorkshire and Bassetlaw into an associate relationship with South Yorkshire ICS. We've got the place-based development, which I'll come on to again in a second, and then we've got the work streams that Idris mentioned previously. So that's just a simple high-level representation of the work and how it's organised to support that overall programme management approach. So I'll stop sharing that now. In terms of the place-based arrangements, we've got the design group that set up a meeting fortnightly. We've got representatives on that group from director and chief exec level colleagues, from key partners such as DVTH, BCVS, District Council, and Notts Healthcare. So we meet, as I said, every fortnight. We are going through some development of design principles for place and thinking about the governance arrangements for place, making sure that we're really cognizant of the HR guidelines, which is in effect that lift and shift model for the majority of all our staff. And obviously conversations are ongoing about those affected at the board level around transition. At the moment, that work is progressing well, but obviously you'll be aware that we are also working with the need to be mindful of guidance as it emerges from NHS England and nationally. There was a tranche of guidance that was published at the end of last week, which we're still working our way through, that will need to overlay any principles and design thoughts and concepts we've got already. Also, there is a really good comprehensive Nottingham and Nottinghamshire design document that's been created, and that will also need to be reflected into any place arrangements that we have. So those sort of things are still maturing, need to be brought together, with the idea that we will come together as a design group to make a proposal to an authority yet to be determined, whether that's an ICS, ICB level discussion and or place executive AO leads of place partners. I think it's all of those, but there'll need to be those ongoing conversations in terms of having a definitive place-based approach, really. So it's ongoing, obviously, with the vagaries of other things that, as they emerge, but I think we're in a good place for where we are right now for thinking, how do we keep our focus on Bassetlaw and make sure that our partners continue to work really collaboratively. We've got some 5 place priorities that we've already agreed, and that's been signed up to across our partners at an exec level and below, through the Bassetlaw Provider Collaborative, for example, and those are around sustainability, same-day urgent care, mental health, health inequalities and inclusivity. So happy to come back, Sue and Sam and colleagues, to a further meeting and explore some of that in a bit more detail once we've been able to mature the conversations a little bit more.
Thank you, Victoria and Idris. Can I just open that up for questions? Oh. Sue?
Yeah, it's not really a question, but it's just to say we would appreciate the detail as it emerges. So yes, please do bring it back, but fully supportive of where you've got to so far.
I think we will be having a further conversation as part of governing body at some point very soon as well, Sue. So I think a lot of that detail might sit more appropriately in there. I think my suggestion would be things that particularly relate to place, PCN, development, primary care, really need to be focused in this meeting. So we'll try and keep those conversations within that remit as appropriate.
And I think just to add on to that, it's around how will this committee evolve? Will we have this committee? You know, I know we will operate this committee until the 1st of April. So I suppose for members of this committee is what will it look like in the future? Okay, thank you. Andrew, 4C, NHS direct commissioning functions to note.
Yeah, this is really just to support the previous conversation. I thought it would help inform the committee of the options that are available going forward. So particularly note on page 38 regarding the take-up of, or optional take-up of other independent contractor functions.
So these are the
pharmacy, dentistry, etc. Yeah.
Pharmacy, dentistry. Yeah. Okay. So they will all be considered as as we progress with the transition.
Yeah, we're able to do that from next April, or I should say the ICSs. You know, with consideration of the last conversation, and the following year it's expected.
Sue?
It was only to say I think Nottingham was originally one of the early adopters of this, so I would be assuming we might be an early taker upper rather than a later one. So we can link into what's already been done in Notts.
Okay, thank you, Sue. Victoria?
I was going to say exactly the same thing. Sue's just puts me to it. I think there's an expectation that we will be going ahead with doing that at an ICS level.
Okay, Idris?
I'm not going to repeat it again. I was going to say the same thing. Thanks.
And I suppose it's not to underestimate the work that will come along with that, you know, if that is the option. Yeah.
But there are a lot of advantages. I do sometimes hark back to some of the advantages of the PCT days when we could be very integrated by, and that's not putting down the work that's been done by NHS England with pharmacists, etc. It's been very good, but actually having everything under one umbrella sometimes, yeah, it does have its advantages. It does have its work. So, you know.
That's what I was just about to say, Andrew. It brings us opportunities, doesn't it, as well?
It does.
Victoria?
Yeah, I remember, you know, when I was a commissioner a long time ago, I had all three of those under me at one point. And if we'd have been able to be in that position, I think when COVID first hit, when we were thinking about pharmacy support and medicines management, things like that, it really brought home how a more integrated approach would have been quite helpful. So I do see it as an opportunity, but you're absolutely right, Sam. This will come with an awful lot of work as well, and hopefully the resources from NHS England to enable us to do it appropriately.
Okay, thank you. 4D, Andrew, COVID vaccination update, and I know you circulated a paper separately on this.
Yeah, I think people are used to getting that update now. Actually, the denominator is increasing all the time. So although our percentage uptake is 86% at the moment, actually our numbers have gone up considerably. Just give you a few highlights. 16 to 17-year-olds, we're heading towards 60% at the moment. I think we're 56.5% on the last figures I sent out, which would have been Monday, Tuesday, and I know there's been some clinics since. So that puts us in terms of SYB quite a way ahead. Quite a few percentage points ahead of the rest of the area. I'm sure we'll end up on the same spot in the end, but I'm quite pleased with the progress for that at the moment. And just a few other things. When the booster program phase 3 comes in, all our PCNs are signing up. We're expecting also our pharmacies to be signed off by probably, I think Victoria Linden said by the end of this week, but hopefully certainly by early next week. Nick, have you got any update on that or?
Yeah, it's so the pharmacies are approved nationally at a weekly meeting on a Thursday. So the existing one at Gringley on the Hill was approved in the first week, and then we've done some other visit. Well, there's one more siting workshop that's been approved to the weekly meetings. So essentially, it's been assured, but it needs to be stood up with all the equipment and supply and everything like that.
Still needs site visits and stuff. Yeah.
That'll
give us a few more advantages in terms of we're targeting communities who maybe didn't access it so much the first time around, to try to increase, well, to make sure we get a good booster take up. in terms of the 12 to 15-year-olds, we haven't had an announcement yet. So we haven't had an announcement of the booster yet, obviously. We haven't had an announcement for the 12 to 15-year-olds, but we've obviously wanted to put plans in place ready, and Notts Healthcare Trust have been really positive in working with us to make plans ready and to start to engage the schools in case there is a go-ahead on that. At the moment, we're trying, there's also a requirement for a third vaccination. So this isn't a booster vaccination for patients who may have been immunosuppressed when they had their first two. And that's a process we're working through at the moment. Now, it's quite a tricky process in terms of making sure that we identify the people who would have been immunosuppressed at the time they had their vaccination. So it's combined work probably between primary care and secondary care in terms of looking at the timing of the vaccination and their immunosuppressant status. So that's ongoing, but I think we'll get a process in place. We're supposed to start by the 15th. So hopefully we'll be starting to call patients in. There were some who were more barn door obvious than others, I think. And that's it at the moment.
Okay, thank you. Any questions for Andrew? Okay, thank you. And then Andrew again, and this is to discuss the enclosed national patient survey results.
Yeah, as I say, this is to discuss. It's the annual patient survey results. Just to say that we do discuss this with every practice individually. So we go through their individual results at the quarterly meetings. We've already started to do that. I think the results are fairly self-explanatory. There were 3 of our practices who are noted for the sort of the key indicator, which is overall satisfaction, were below the national average. That was Westwood, who've been below the national average ever since they changed from a 7-day-a-week 8 to 8. And I don't think we can always just look at that. But as Lara would point out, they do have pretty much exactly the same system as Larwood, whose satisfaction is above the national average. So I think there is still probably a bit of a hangover from that period of transition, which was about 6 years ago now. And then there's Newgate and Riverside. I think the common thing that we probably ought to realise, well, we would realise, is the phone access seems to be still a common denominator for those 2 practices. And we've had quite intensive discussions with both of them about improving, but I think we probably need to have further and to think about whether we need some sort of across the CCG plan to try to ensure phone access. That would be the other thing I'd say is, given that we do generally poorly on a given time for their appointment, but I think that possibly represents the fact that if you look, a fair few of the practices who do poorly on that are the asthma GP practices who don't work in that way. So they do the clinical triage. So that possibly explains why the CCG overall performs poorly on that one. And the other thing is, I know even within some practices who have got a very high satisfaction, there's the odd indicator that where they patients have obviously deliberately chosen to say, I'm just not quite so satisfied in that one. And that's something I do hone in on at the quarterly meetings. Hesh, I hope you don't mind me saying that Crown House and Leverton, who've both got excellent patient satisfaction results, there's just 1 or 2 indicators. So we tend to look at that and ask the practices to hone in on that one, because that's specifically where people have gone, I'm really satisfied, I really like the access. In Hessian's case, in Crown House's case, love the website, etc. But I've just got 1 indicator here where I'd like you to focus, and I think that's really a useful aspect to this survey.
Okay. Andrew, just on the phone access, would you like to capture a next step around that?
We have looked, I mean, Victoria, we have looked at the possibility of actually having some sort of combined phone access, so kind of a hub approach, and whether that might be feasible in the future. We've individually talked to the practices in question, and Newgate have increased the number of people they've got on at key times of the day and tried to improve them. And to be fair, when I've tested, I do test out practices, I do phone up, I try not to, ironically, always phone at the busiest times and therefore clog up the phone lines anymore. But I do test, and actually I've not really had a massive problem. I may have just been lucky, but they have increased, so they switch over to a lot of their other staff. But they've only got so many phone lines that can go in and out. So maybe we need to look at a technical solution for that for them. Riverside, who also, you know, don't perform so well on, and we've had a lot of recent patient concerns around phone access. They've employed a lot more staff to answer the phone recently, so we're hoping that they'll turn things around. And they're also looking at different ways of accessing, so for non-urgent, having email contact, that kind of thing.
Okay, Victoria, did you want to come in on that point?
I think Hesh was before me, Sam, so let's Hesh go first.
Hesh. Yeah.
Thank you. I suppose the first one is I was going to say thank you to Andrew for pointing out some of the outlying indicators from a Crown House perspective, which is very helpful, and we've got a solution for that. I won't go into that here because it's probably not relevant, but it is very helpful, Andrew, those quarterly meetings where you do pick up certain things, because sometimes for lots of practice, including my own, going through reams of charts and data to pick out the key themes can sometimes be challenging, so it's helpful to phone in on that. My next point was around the telephone issue, and I think it's an issue for everyone. I'm not just talking Bassetlaw, I'm talking nationally, because there's been a big transition in terms of how primary care functions to doing far more telephone triage and virtual triage, etc. So I wonder whether there's any appetite for a infrastructure analysis, whether the CCG could support to have the practices kind of IT infrastructure looked at to see whether it's more of a infrastructure issue, i.e. lacking infrastructure, or whether it's an efficiency issue in terms of how that infrastructure is deployed. I know from my practice's perspective, historically, we didn't really have any major issues. Now, at least 50% of us are calling out GPs at any point in any given point in time when patients are trying to ring in. So if we have the same number of telephone lines, and historically we didn't have many going out and a lot more access for people to call in, then clearly there's going to be a delay in terms of when they're trying to ring up when the GP is trying to talk to another patient and using up a line, isn't it? So I haven't come across any national standards in terms of, you know, you need to have X number of telephone lines if you have a certain population size that you cater to, etc., etc. So I wonder whether there's any experts that we could tap into, who could come into a practice, just do a very brief review and say, look, you've got the right level of infrastructure, therefore it's about your organization looking at efficiency, and these are the areas that you could probably look at, or whether they say, look, your telephone access is wholly inadequate, the number of lines coming in, we would recommend you have X or Y number of entry points into the surgery. So I wonder whether that's something that could be looked at, please. Thank you.
Victoria, can you pick up on Hesh's point?
Yeah, it was the kind of thing I was going to say. I think first of all, the results actually are very positive. We still perform really well. When you look at the regional comparison, actually Bassetlaw still offers a really good high quality services of primary care for the patients of Bassetlaw, and I think it's really worth stating that. And we know that our PCNs and our primary care continue to work really, really hard under some very challenging circumstances, particularly at the moment, to continue to provide primary care services. So I think that's really worth stating, Sam, and being clear that we recognise that and appreciate the hard work that does go on, both from clinical and non-clinical staff. And non-clinical staff equally have found the challenge of the COVID period very, very challenging. So I think we need to recognise that and give our appreciation for it. I think where we are now, Sam, is we are moving into a new era of the way that we support primary care to develop. And I think there needs to be a new focus moving forward. It's kind of on that OD agenda. And I do think there's going to be an expectation as ICSs and ICB emerge and mature, that place will be where we do support PCNs to mature very, very in an accelerated way, I think. So I think going back to Hesh's point, and Andrew mentioned, we've been thinking about how do we support our primary care to respond to what has been a massive increase in demand. We are talking about tens of thousands of phone calls a day for practices that have not historically dealt with that volume. we've got a changing demand and the nature of demand from our patients. And obviously that's not only dealing with the here and now, but also the backlog, if you want to use that terminology, from what's happened before and what's not being seen, you know, the needs of patients that's not been addressed as a result of COVID, and we all understand the reasons why. So I think there's something about how do we emerge from this more resilient, and there has to be, I think, a step change almost in the OD for our PCNs to support that. And I think for me, it's maybe working much more closely with the CEDs and with our practices independently to think about what that looks like. So kind of much more of a, how do the PCNs to come together, to work together, to tackle those issues that affect all of them. And telephone answering and appointment making is a key one. I think same day urgent needs primary care is also another agenda item. So I think going back to Hesh's point, in a way that we have ECIS going into, for example, acute environments, I think what I'd like to explore is there something of analogous for primary care that we can come in, because I think Hesh is quite right. We've got to understand what the particular problem is or problems are. So is it about an infrastructure issue, the nuts and bolts of the telephone system and telephony? Is it about capacity of people to pick up the phones? Is it about the skills and training of the people picking up the phone? And or is it the handoff points into other services and the navigation? And also the patient demand element and what is it that people need support and guidance on, and other routes to get them to that. So I think it's a really broad ranging issue. So I think that as part of moving forward as a place plan and thinking about our priority around inclusivity, that's a piece of work that sits under there for me, working very, very closely with our PCN colleagues to see what the opportunities could be.
Thanks, Victoria. Idris?
Thanks. I think I'm going to reiterate some of the points that are made, but I probably might put a bit more emphasis on something, because overall, as Victoria said, you know, these results are standing up really well, surprisingly well, considering all of the publicity and bad press and how stretched primary care is. It's probably worth noting that primary care in this country is significantly under-resourced if we compare it with much of the rest of the world. You know, so if you look at the OECD countries, there's only Poland that's got less GPs or similar per thousand population across the whole of the OECD. And you know, the funding for primary care is around about £155 per head, so £155 per 100,000 for a year. Pet insurance is about £400. You know, it just doesn't compare. So, you know, keeping on getting the really positive news stories out of primary care to try and create a bit of balance, I think is helpful. And on that, one thing I just wanted to note, because receptionists get a really bad press in primary care, and I've lost the figure now, 91% said that they were helpful and things, you know, which is totally the opposite to what you hear either in the pub or on the press, you know. So there's probably something there that we can do to promote and recognise, you know, the hard work of the receptionists and how well actually they are regarded by the vast majority of the public. In terms of, you know, what we do with the information, I think we pick out the areas of biggest challenge, which is predominantly accessing by phone. And if we can crack that, I suspect our figures would go not just at around about the average and maybe in many cases just a bit above. I think we would become the best in many of those, you know, in the country, just with that single issue being resolved. And I know it's multifarious, which is fine, but I think that's the one that we ought to put most of our efforts in.
Thank you, Idris. Lee?
I just wondered, picking up on Esha's points about some support for the IT infrastructure for PCNs, I wonder if we could include that as part of the Ask for the PCN estate strategies. I know Retford and Villages PCN, their estate strategy introduction to the project manager for that was made last week, and they're starting to do some of that scoping for that. I wonder if we include it in the scope of that work. I know, Victoria, Andrew, we've got a meeting to look at signing off the fee proposal, but perhaps we move some things out that we know we've done, primary care data gathering, for example, and put in telephone and infrastructure, telephony and infrastructure. And then just to know as well, I wonder when she said about what's working well, on the national survey, we do get to know which PCNs, which practices will be rated good, don't we? Do we contact a few of those to ask what they're doing? And then just as a final note, whilst there's no capital around, extension of telephony can be funded under BAU improvement grant. You can't have a new telephone system, but you can have an extension to one. That's it.
Okay, thank you, Lee. So just to try and summarise all that conversation, these are good, positive results in what's been a difficult year and continues to be a difficult year and very, very challenging circumstances for staff, and that is acknowledged and thanked. There are some areas, particularly the telephone, that needs further work. It is acknowledged and there'll be plans in place to look at that. Two things, I suppose. Do we want to formally write from the committee to both practices and also I think maybe to receptionists? As Idris has said, you know, the receptionists at the first point of call, they sometimes take difficult conversations, they're navigating thousands of calls, and should we send, you know, a letter of that, you know, thanks and appreciation to the practice receptionists? Idris?
I'd be interested to reflections on the people about sending a letter direct, as opposed to the practices who employ the receptionists, giving them the recognition as their employer. I was wondering if we ought to do a press release that said, you know, what the results looked like, drawing out in particular, you know, how good the receptionists, you know, sort of come across. I know it can be difficult to recruit some receptionists, so a bit of good press in the public domain, I think might be helpful. And of course, in that, we could recognise that one area that we're going to look at and to improve is the telephone access. I've got no problem with sort of recognising that. But I think it is a good news story. It's important we get good news stories out and an opportunity to just put a pat on the back to the receptionist at the same time.
So perhaps, and just we send a letter noting what you said to the practices regarding the results, but note within that letter the positivity around receptionists. Yeah,
and we could pull a press release together.
Yeah, like Victoria and Andrew.
Yeah, happy to endorse that as an action. I think give the action to Andrew and myself to draft an initial press release on that one.
Andrew?
Yeah, I just thought it might be worth pointing out a gradual improvement. As looking at the results on previous years, a gradual improvement on those practices who went on the Ask My GP system, which is something that's been introduced by, I think, probably in a kind of form by all practices over the last year or so, because they've had to. But if you look at Tuxford's results and Larwood's results, they took a dip when they first moved over to that system. They all described it as a bit Marmite, and patients were nervous of it, I think. But if you look gradually after a couple of years, their results are swinging up and improving year on year, just by a little bit. But I think people do get used to the system, and they get used to having the access that it provides, and I just thought it might be worth noting that. So maybe that's an optimistic thing for a lot of practices in the next couple of years.
Okay. Thanks, Andrew. So a really good discussion on that. Next few items for noting, 4F on the blood tubes issue. Andrew?
Yeah, it is just for noting. We have been constantly communicating with practices about this issue and about the requirements of trying to avoid doing any non-urgent blood tests, and the same when primary care has reported that the acute trust had been asking for blood tests that don't seem to be urgent. I was anticipating that we'd have some practice level, or at least CCG level, usage statistics for this committee, but at the moment we've not been able to get hold of them. So we're only getting overall usage by primary care across Doncaster and Bassetlaw hospitals, which doesn't seem to have dropped an enormous amount, but I'm expecting the impact of the various messages that we've sent out will start to come through now. And I know when we've discussed with practices, they are they are trying their best to reduce the usage of these blood tubes. And I know that DBH and everybody else is trying to alternate sources for tubes. I think that's probably about the only thing we need to say on this at the moment, because there's no real actions for the committee other than to note it.
Okay. Any questions?
Oh, the only other thing I should note, sorry, Sam, is that we
Okay.
have raised, and I think a lot of CCGs will have raised this, whether there's going to be any changes to QOF as a result of this, or any of the nationally mandated work that involves taking non-urgent bloods.
Okay. Thank you. Next one, 4G enhanced services, long COVID and weight management sign up. This is verbal to note.
Yeah, this is good news. All our practices signed up by the deadline. So again, I put this on when I wasn't sure whether that was going to be the case and whether we needed to work with the practices to see why they wouldn't sign up. But they all have, and have started to refer into the weight management service in particular already. So there's nothing else to note. It's a good news story, as I say.
Okay, thank you. 4H arrangements for antiviral medicines for flu outbreaks draft. This was sent. Yep.
We resent this out, didn't we, Charlotte?
Yes,
when we Sally and
Yes.
myself had looked at it, and we're required to have it in place by the end of the month. Rob Wise is on annual leave at the moment, so he's just going to check in terms of where the stores are held, basically, and he's going to check with some counterparts on that one. But other than that, this won't substantially change now. So if the committee could approve it in draft, then the fine detail, we will send it out for information, but I don't see it substantially changing before we approve. Eshu?
Just a quick question. Am I right in thinking that the care homes, the vast majority of the care homes, do have a care home community frailty matron employed by an NHT who supports the care homes? And I'm wondering, because on this algorithm, it very much refers to the GP in terms of doing the assessment to see whether someone's got potentially flu or not, rather than deploying the GP, whether there could be some sort of collaborative working with the care home matron, doing some of the assessments, working with the GP. And we wouldn't expect the care home matron to prescribe or do those assessments, but in terms of the physical assessment of the patient, I wonder whether that's a resource that we could use in this process.
Maybe if we instead of GP we put PCN team B, because that includes the Notts Healthcare Trust. So then it kind of leaves it a little bit open then, though. And I don't think the Notts Healthcare Trust resource would be something that we could definitely nail on.
Would it be worthwhile asking whether they do have the ability to support? I mean, at the moment, for example, we've got access to Call for Care. We've got access to if someone's got COVID in the community, we can deploy the COVID visiting service to go across, do assessments. So all the GP needs is a set of observations and also use a video consultation if required to have a look at the patient. So it does not require the GP to go out to the care home to assess, as long as you can get observations. Now, I know that you shared some stuff around IT stuff that you could potentially use to train up the care home to do the assessment themselves, but that might be a longer term goal. So I wonder whether that resource could be the existing resource that's there to support patients who potentially got COVID in the community could be refashioned in some way to do a quick assessment of patients in care homes.
Yeah, we can certainly raise it, Hesh. I mean, I think to put it in context, this policy was only enacted a few times last year, so it wouldn't be that we'd be asking for an enormous amount here. I think it was maybe not last year. I don't think it was at all. I think the year before when we did have flu, it was only maybe 3 times. It's something like that. So I think, yeah, it's not a huge ask. We can raise it, certainly.
Thank you.
Victoria?
I was just thinking, it says GP to assess, it doesn't mean direct assessment. So you could say, for example, GP to assess, like comma, directly or on the basis of information provided from other clinical health and care professional, whether they're clinically confident the patient has flu. So you could put something as a bit of a rider on that one, couldn't you, Hesh? But ultimately, it's still making sure that a GP retains that kind of overall accountability. But I think it can, you know, define assess a little bit more loosely, perhaps.
Charlotte, sorry, on that note, could you put down an agenda item for me to update the committee on the implementation of the remote diagnostic kit that we're putting in place? So I won't do it in much detail yet, but I think you'd be interested in the potential of this. We're running a trial with the Academic Health Science Network at the moment to put in remote diagnostic kit into 5 care homes. So basically, it means the GP can assess remotely. The care home staff are there and actually direct the equipment, and therefore the GP can do an urgent visit without doing an urgent visit. But it's just 5 to start with, but potentially I know that it looks like we've been successful in gaining 50 pieces of kit going forward. So that would cover at least 1 per care home in Bassetlaw, probably a couple, and we might look at people like Call for Care also having that kit, so that again we can use our primary care time more efficiently and improve access. I'm quite excited about it. I think it's real, and it's worked really well down in Newark and other places who've sort of reported back up to us. So hopeful.
Okay. Thanks. So on that one on the agenda, Andrew, it's to note. So you asked for approval, and I know the updated flowchart was circulated this morning. So
yeah, I'm sorry, Sam. That should maybe if we could do it virtually. We just got to do it by the end of the month. So I tell you what, Rob's coming back I think next week. Why don't I get Rob to do the final bits of check, and then we're approving the final version. It was just wanting some feedback at the moment, but I did think we might approve it today, but it's probably better to do it like that if everybody's okay with that.
Yep, that's fine.
Okay.
Thank you. Next item, demand on GP appointment data, and I know you circulated an email as well, Andrew, on this.
Yeah, I think the level of detail will improve over the next couple of months. I looked at the GPAD data, and there's quite a lot of detail on there. But I'm just really monitoring in terms of the committee, in terms of whether we are matching, and this is only measured. You know, every GP practice, I think, quite rightly points out that the measure doesn't capture every kind of clinical or other engagement that practices have with patients. So it's only a proxy really, but we are running, or our practices are running a bit higher than 2019, certainly higher than last year, which is what we're required to be monitoring at the moment.
Okay, thank you. Any questions? No? Okay. Thomas, I just wondered on the digital and IT, if you wanted to go next, then you're free to leave, or are you happy to carry on as we are?
No, I'm happy to listen in and get the update, but thank you very much.
Okay, thanks. Section 5 then, service development. Victoria, long COVID clinics update. It was down for Faye.
Yeah, again, I think this is just for information to note really, Sam. But obviously, we've already had a conversation to execs, and we've provided additional investment to support and bolster our long COVID clinics to make sure that they meet the needs of local patients. Obviously, we'll continue to explore development of that with Notts Healthcare colleagues. The investment will bring support around physiotherapy, and obviously we've already got the support around IAPT. Things that we do want to explore more is more direct access for referrals. So I think there's nothing more to add on that, Sam. It just except that it's in situ, it's working well. We've got patients going through. Over 90 referrals have been received to date. I think it's gone up slightly since then as well. I think obviously that shortness of breath, that fatigue still seems to be one of those key issues that we need to resolve for those patients. But I'm not having any particular outcomes from that yet. So I think that's where we need to get to next time. Is we know what's going in, we don't know the impact of patients and patient-reported measure coming out of it. So I think that's something we probably need to investigate further now it's a bit more established.
Okay, thank you. Next item is the report that Hester presented the slides for from Health Watch at the last meeting. So that's just to note, unless anybody has any questions. Okay. No. And then over to Andrew with the Bassetlaw flu plan. And again, this was circulated as an additional paper.
Yes, so I think it's really just a note at the moment. We've got draft flu plans in place. On a positive note, a very practical note, we did think that the delivery of the flu vaccinations was going to be delayed, and we were concerned about that. But I spoke to Larwood yesterday, who had one of the early deliveries, and theirs came on time. They'd initially been told it would be delayed by quite a while, but it came, and they're actually also investigating whether they can get additional deliveries as well. So the supply problems that we really feared might happen and might also collide with the COVID booster program don't seem to be materialising. That's very much a touch wood at the moment, but early indications are good.
So at the moment, Andrew, you can't have the flu vaccine and the booster together, is that correct?
That's the current guidance. We're expecting whether that changes with when the booster program's announced, but the current guidance is no, they've got to be 10 days apart. I think it is.
Right.
Apart from the nasal one, sorry, the nasal flu, you are allowed to. Doesn't mean that we will deliver it at the same time, but you can do the nasal flu and the COVID jab at the same time.
Okay. Any questions on the flu plan? No. Thank you. And then on to 6, which is the finance report, on to Michelle.
Thank you, Sam. I'll take the paper as read, but I'd like to draw your attention to a few points in there. So the CCG is forecasting a small overspend for the first half of the year. This is primarily due to the locum claims that we've seen that have been high again this year. We've received, or we're expecting to receive, claims of about 49,000 for the first half of the year, which is against a budget of 31,000. The costs for this are difficult to predict, as you know, but we do seem to have had large claims in the past few years, following a few years when we had virtually no claims. So it is one area that we do need to look at in future and make sure we've got sufficient budget in there for that. In terms of the additional roles, so the R's scheme, we've now received confirmation of the funding that's available to the CCG. The way it's been distributed by NHS England does mean that we've received around 92,000 less than the maximum that can be claimed by the PCNs. So that does leave us with a financial risk if all PCNs claim up to that maximum amount. So we are monitoring that closely as we go through the year. And I'd also like you to note that following the 3% pay award announcement, NHS England have clarified that there'll be no increase to the GP contract values and global sum, etc. And similarly, there's no increase to the funding given to CCGs in respect of GP practice costs in relation to that that pay award. The rationale for that given is that the uplift is a matter for the practices to decide whether they implement. It's just a recommended increase for them. So that's the situation we're in, and the practices will be in for that. Just an update on the second half of the year, sort of breaking news. So we had a CFO briefing yesterday given by the senior finance staff from NHS England. That confirmed that the arrangements for the second half of the year, or H2, will be broadly the same as we've seen in the first half. But we're still awaiting the details of that financial settlement for the system and for the CCG in turn, and they're not expected for a week or so. So I'll update the committee as we receive information on that. The financial planning and the whole planning round is due to be completed by early November, so it is quite tight deadlines on that. So I will update people outside of committee on that. And just finally, another issue that's arisen since the paper was written is that we've received the details of the requirement in the GP contract for CCGs to publish and share details of our primary medical care spend, and sharing that with the LMC. We've got a template from NHS England for doing that, and we're working on pulling the information together. The requirement is that we publish 1920 information by the end of this month and 2021 information by the end of December. My suggestion is that given that timescale, particularly the end of September 1, that I share drafts of that information with members of the committee by the end of next week, to give us a couple of weeks to be able to review that information prior to publication. And hopefully we can just publish both years at the same time as well, rather than waiting till December, if that's okay with members of the committee.
Okay, thank you, Michelle.
Thank you. Happy to take any questions.
Andrew?
Yeah, Michelle, you mentioned the R scheme and the funding we've received for that. I've put a separate item in confidential that has got the 3 plans of the PCNs at the moment, in terms of, you know, ideally I think what they'd want to spend. I take it that underfund doesn't affect our decision making process in terms of reallocating that.
No.
No. Thought it was worth noting in public that won't affect our thinking in terms of the potential bids for the underspend. Right,
it won't. It just gives us an extra pressure.
Yeah.
Thanks, Andrew.
Cheers.
Sue?
My question was around the hours as well, because the current spend was showing an overspend by some in relation to on ours. Are they still within their allocation? Is that what will be a pressure on the actual total budget we have available?
Do you want me to come back on that one, Michelle?
Yes, please, Andrew.
Basically, those are plans for spend. So what they can do is they can say they plan to overspend, and one of our PCNs has said that at the moment they're looking like an underspend. And what the other 2 can do is then make a bid to say, I would like some of that underspend to be used on our overspend. So that's the process that we'll go through in the next 3 weeks.
That paper's in confidential papers, though, isn't it? Yeah,
that's fine. Thanks.
Okay. Thank you, Michelle.
Thank you.
Andrew, Primary Care Networks, verbal update.
Yeah, I've also put in the details of what's required of the PCNs over the next year. I thought that would be something that's it's quite key for our implementation work, but it's also of interest for the committee. I'd note a few things. There's a £43 million national funding pot for PCN leadership and management. So that really continues what's been in place during the COVID vaccination campaign, but it's not specifically for the PCN CDs. It's for overall support and management of the primary care networks. And also note that it's weighted in the same way that our overall primary care allocation is. So proportionately, we should get a little bit more than average because it's demographically weighted. Note the CVD implementation will be around hypertension. But we've started to look at the implementation for next year, because next year is going to be AF, heart failure, hypercholesterolemia. So that's going to have, I think, more of an impact as well on referrals and some of the diagnostic stuff that we do. So it's just worth noting. I don't think hypertension, and Ash, forgive me if I'm wrong, will have an enormous impact on other services. And it's all welcome. These are areas we've had various focuses on in our incentive schemes over the last 10 years to try and increase our detection rate for these. So it's definitely welcome. It's just worth noting that there's going to be an impact, I think, on the wider system when we do focus on them. The other things I'd note, the inequalities preparation, we've already noted that sort of dovetails in quite nicely with our incentive scheme, and we can accelerate that, I think, a bit this year. And extended access formally goes to PCNs directly in April 2022, which for us doesn't really make a great deal of material difference. I don't think. I can't see that there'll actually be much of a difference in the actual service.
Okay. Thank you, Andrew. Point 8, workforce updates, Andrew.
I've put this, the main thing I wanted to discuss was the R's plans, and I've put this because it's got specific financial PCN sort of proposals in detail. I've taken this into confidential, so I just wanted to make that note that the underfunding that we're getting won't affect our decision making when we go to confidential.
Okay, thank you. And then,
sorry, there was also a note about the nurses, wasn't there? We've had one application for the VTS program, so that's just in progress at the moment. If you remember, we agreed to fund £10,000 per nurse for up to 3 nurses. We've had one application for it, so hopefully that one will work.
Okay, thank you. Digital and IT update, Thomas.
Morning. I'll take the paper as read, but we'll draw attention to a number of key points. So I'd like to mention on the KPIs and the statistics, KPI 1, which is the 95% target, we've not achieved that for 3 months running, but we've got processes in place and an improvement plan, and we're aware of where the failures are. But we would note that the average answer time for calls to the service desk is still below 30 seconds across that same period. So we're still managing to answer the phones as just peaks where that goes up. We mentioned on a number of reports around the Wi-Fi controllers and delivery issues. They've now been received at the time of writing the report. They'd been received at Greenwood. They've now been delivered to 722 and installed, and we're configuring those. So that Wi-Fi rollout that's been delayed for a number of months, it will start to trickle through now. So really pleased with that. And the additional hardware for the disaster recovery site at Hilda House, that's been installed, and we're in the process of replicating and testing, replicating the data and testing the setup. But the offline backup functionality, which is where we take an air-gapped backup, which protects us against ransomware and encrypted attacks, we've got a process in place to take regular full backups of all our data that's held in the data centers, so that we can move that away from the network and keep us protected and give us a good secure restore point. So that's some good news there. But happy to take any questions across that report.
Thank you. Any questions on the IT digital? Okay. Thank you. And then on to 10, Lee, general estates update.
Okay, let me just find my paper. There's not actually a lot to update this month, which is a nice change. In terms of primary care data gathering, we've actually done quite well. I think Nick will have a better figure nationally of how that's doing. The programme is now finished. There was a requirement to have 100% of information submitted, and the practices have worked really hard, clearly, to get the information together. We've got an 80% compliance. The only outstanding practices being Larwood and Westwood, but the manager had asked for an extension until the 23rd of August. I will take an action to follow up that's been submitted, and then we will have 100% compliance. Going forward, primary care data gathering on this is going to be input onto the SHAPE tool, and some of that already is for Bassetlaw, to be fair, but it is the tool that's being used nationally when looking at estates and estates planning, and increasingly I understand that the local authorities are going to be putting on their housing development plans as well, and I understand it's actually going into the ownership of the local authority, but again, Nick might have more info on that. Primary care network estate strategies. So you might recall that the CCG had secured some resource to support each of the PCNs to develop their own estate strategies. That's started now. North Nottinghamshire Lift have met with Ellen Azar from Retford and Villages as the nominated lead for estates, and and I presume that we'll start to get asked a lot more questions. As I said earlier, Victoria and Andrew and I need to look at what the fee proposal is, and there could be an opportunity there to include telephony as part of that ask. Misterton and Gringley, both practices are on open market. I think there has been some interest, but I don't have any further update than that. The GP owner is looking at doing some improvement works that we identified as part of being happy with the lease approval, and they have got 2 quotes. So I was waiting on a 3rd quote last week. As soon as that comes in, we'll be able to submit the IG application to NHS England for capital support, and that'll be on a BAU basis, which is funded 34% by the practice and 66% by NHS England capital. Newgate Health and Wellbeing, it's in the paper what the stage gate 5 actions were. Most of that is now completed. The only bit that we've got to finalise is around net zero carbon. The issue that we've got with finalising that are twofold really. The costs go up by 25%, so it's to what level do NHS England want to go with the net zero carbon proposal, and equally we can't get any guidance from NHS England at the moment about what they want net zero carbon to look like in their estate strategies, and that in the business cases, sorry, and that isn't just locally. I was on an estates update call just this week, and the primary care commissioners who were running that workshop said they've asked and they can't get an update either. So it's quite difficult when locally we're being asked to include what our strategy is for that, but we can't get the national steer so that we understand what would be expected to be seen. The next stage gate review is at the end of September, and that'll be stage gate 6. At that review, schemes will either be on or off. So at that point, we will know if it's going forward or being parked and not progressing.
Okay.
Any questions?
Okay. That's great. Thank you, Lee. Next items are items for escalation. First one is quality and patient safety. Cathy, I know you've joined us as Nicola is away. Not particularly for escalation, but we did note that on the agenda of QAPs, we have considered vaccinations and care homes uptake, and I'm sure that will come up next week in the meeting. And nothing particularly to escalate to governing body. Sorry, Cathy.
Not that I'm aware of. Nicola's not asked me to escalate anything today.
Okay, thank you. Andrew?
I'm not sure whether QAPS has got the arrangements for antiviral meds on its agenda, so we probably ought to note that it's been approved here otherwise, because it was a bit of a where do we take it conversation. So okay. We'll just note it next week, shall we?
Yep. Okay, thank you. Nothing for governing body unless anybody else feels different. And Sue, anything for audit? No. Risk management, we've currently got 2 risks. First one, low risk, additional roles, recruitment, and August, it's a mitigated risk and an accepted risk. And the second one, workforce resilient, we've got that as a low risk currently. Nothing else to add, I don't think. And any other business? No?
I wonder, Sam, could we just formally thank Faye and Sarah? And you mentioned that Faye's leaving and Sarah's actually already gone, but Faye particularly did a lot of work for this committee, and it would be good to thank her.
Yeah, we will do that, Andrew. Thank you. We'll formally record that. Next meeting on a bonfire night, Friday the 5th of November. So we'll formally close the public meeting. If you want to take 10 minutes for a coffee, and I'll see you in the confidential part A. Thank you.